Welcome back to PedsCrit. I'm Zach Hodges, a pediatric intensivist at University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
Today, we have the privilege to be sitting down and discussing high-grade AV block with Dr. Robert Pass. Dr. Pass, please get us started. Introduce yourself. Tell us who you are and what you do.
Hi, nice to be here. My name is Rob Pass. I am a pediatric cardiologist and an electrophysiologist as well as an interventional cardiologist. So I'm a bit of an oddball, and then I trained in both areas, but I think most people probably know me as an electrophysiologist. I'm the chief of pediatric cardiology at Mount Sinai in New York City for the health system. I'm the co-director of the Children's Heart Center here. And some people know me through my podcast, which is called Pediheart, Pediatric Cardiology Today.
That's excellent. Dr. Pass, you've had a very successful career in all aspects. You just reviewed for us your excellence in clinical care, being division chief and leadership there, as well as traditional scholarship. And thanks for introducing the Pediheart podcast. You know, I've been following this as long as I've been interested in critical care. You started this podcast in 2018 and now have nearly 400 episodes. I'm curious, even in 2018, why did you see this as an important work to start, and why do you keep this going in 2026?
Well, it's an interesting story why I started. In 2018, I was, 51 years old, and I was thinking more about retirement. And so I started listening to podcasts about retirement, of which there are many. Because, you start thinking, well, I better make sure I can fund my retirement. And as I was listening to a lot of wonderful podcasts, and that was pretty much when podcasts started to become more popular, I then asked myself the question whether there was anything on our field in pediatric cardiology. And in fact, there really was nothing. The only thing that I could listen to was Dr. Valentin Fuster, who I'm very friendly with here at Mount Sinai, colleague, used to be the editor of Jack, and they have a podcast every week, and maybe once every 2 or 3 weeks he would review one article that had something to do with congenital heart disease. But aside from that, there really was very little in pediatric cardiac realm, and so I thought it might be a nice idea to review some of the literature in pediatric cardiology. I'll be honest in saying that one of the most important rationales, in my view, for doing it also came from an observation I made watching the Oscars and the Tonys on television, which was that it struck me as odd the way actors would stand up in front of the audience when they won an Oscar and acted as if they had solved for plutonium or developed a nuclear fission. And it just, when I think about the kinds of things that you guys do and all of our colleagues do in pediatric critical care, pediatric cardiology, adult congenital, taking care of thousands and thousands of patients, saving lives, it just seemed odd to me that we so honor these wonderful artists who do wonderful things, but really, you're honoring an actor who participated in one movie, maybe worked for 6 weeks, and people like ourselves are essentially never honored in almost any way except rarely with an award here or there. And I thought this was an opportunity also, even in a little bit, to highlight each week one person and what they're doing in our field and how wonderful it is what they do, because I think what we do is very important and very special, and I think we're not kind enough to each other. And so I think having the opportunity to, even if it's just one doctor at a time, demonstrate what a lot of important people are doing, I think is a nice thing to do.
Oh, well, that's wonderful. And we certainly appreciate it and agree with you. So you've been putting out this podcast weekly, which we think is awesome, for so long. But that's not the only thing you're putting online for cardiology learners. You also have a weekly electrophysiology conference that you've been putting out pretty consistently that people can use to learn from. Can you tell us more about that?
One of the other things that I do other than the podcast in the realm of sort of public education is I have a YouTube channel in which I review electrophysiology every week. And there are now nearly 250 videos, which is just our pediatric EP conference. And the reason I post that is it started during COVID when a lot of programs stopped having lectures. And I thought, well, since we're doing it, maybe it would be a good community service. And then once COVID was over, I told the fellows that I would be happy to just do it in person again. But they actually wanted to continue it online. And they were very adamant that I continue to post them because I guess sometimes they watch them over. And so I've been doing EP conference since 1998 in my first job every week. But I think People seem to enjoy it. And electrophysiology, as you know, is an area that people sort of get and then they lose it because it's not something you use on an everyday basis. And so I think the goal of that is to really be as repetitive as possible to drill in very important concepts in electrophysiology.
Well, that's excellent. As we transition to today's topic, I will say much thanks for your contributions to podcasting, videos, and making knowledge in pediatric cardiology accessible for so many people.
That's very kind of you to say. Thank you. It's my pleasure.
As we get into the topic of high-grade AV block, any relevant conflicts of interest to disclose?
No, but I'm always open to any opportunities anybody has one.
The best answer.
Excellent.
Alice, give us our case.
We're going to give you an 8-year-old girl who presents after syncope while playing soccer. On exam, pulses are present, but she is pale with prolonged capillary refill time and hypotensive at 80/40. Telemetry is showing frequent non-conducting P waves and a wide ventricular escape rhythm at 40 beats per minute. IV access and an EKG are being obtained. All right, so Dr. Pass, if we had the chance to take care of this patient with you at the bedside, what are your initial impressions of the case?
Well, the first thing, of course, you want to make sure is that the patient is stable, has brisk capillary refill, is talking to you, has reasonable perfusion. I think, you guys have taught me that blood pressure is a very late sign of impending doom. So there are a lot of things that can cause heart block, right? I mean, the first question is first to look at the 12-lead ECG. And people know who've worked with me or have studied with me that if you were going to get one test on any patient who has any kind of rhythm disorder, if the patient is stable enough, it is always important to get a 12-lead or a 15-lead electrocardiogram. I would make that observation for virtually any arrhythmia. Oftentimes, for example, in post-op patients, people are running to do atrial wire electrograms and things like that. But really, if you were only allowed to do one test, a 12-lead is the critical, most important test because it's not uncommon that a single lead of the ECG will not be as obvious or clear. And sometimes, just the other day, a cardiologist asked me to look at an EKG where in 2 leads it looked like the patient was in 2-to-1 heart block, but in every other lead it was very obviously not the case. And so having a 12 lead is a very important test, and I would strongly endorse doing that, again, in the event that the patient is stable. But you're describing in this scenario someone who's in high-grade AV block, maybe second-degree block. Once that has been established, then you want to get a quick history to figure out if, what the possible etiologies of this are, particularly if the patient is stable. This patient, it sounds like, is somewhere between stable and maybe about to become unstable. In children, the most common cause of any kind of heart block is actually cardiac trauma from cardiac surgery. So that would be the first thing I'd ask is whether this patient actually had heart surgery, because we do such a good job with our patients that certainly most of our patients play soccer. You could easily just do an examination and look for a sternotomy scar or a thoracotomy scar or something like that, because that is certainly a possibility. And I should add that it is not unheard of for patients to have late heart block. You can have normal conduction following open heart surgery and years down the road develop heart block. We even wrote a paper on that many years ago. Many other works on that have come out. But assuming that that is in fact not the case, then, we talk about things like myocarditis, toxins, tumors, Lyme disease, hypothyroidism. These are probably the most common causes of that. You can have low-grade heart block with elevated vagal tone, but this example is someone who's actually having syncope while playing soccer. The interesting thing is, you describe them having heart block. When you hear of any patient who's syncopal during exercise, that is immediate call for evaluation. And really the most common thing would be a tachyarrhythmia, something like catecholaminergic polymorphic VT or maybe long QT syndrome or something like that. So this would be an unusual presentation to have somebody who is in heart block while playing sports. And, again, it just speaks to one very important point is if somebody has exertional syncope, that is a very, very important red flag that probably deserves hospitalization, but definitely deserves a very extensive evaluation. It's very hard to imagine a benign cause of exertional syncope in a child.
No, I really appreciate that. You very astutely have already identified this patient as heart block. Will you tell me what about this vignette It lets you know that it's heart block and not another type of bradycardia.
Well, just to take a step back, right, there are essentially three forms of heart block. In first-degree heart block, every P wave conducts to the QRS, so there's a P wave before every QRS, a QRS after every P wave, but the PR interval is long. And in most children, that would mean over 200 milliseconds. In a very young child, maybe over 170, 180. And then the other easy one is third-degree heart block, where no P waves conduct. And so there's, typically when someone is in third-degree heart block, the ventricular rate is relatively fixed. It may vary over long periods of time, but on a typical 12-lead surface electrocardiogram, there should be no variability or virtually none. And that's a very important clue for complete heart block. And then the more difficult one to sort of ferret out is the second-degree heart block. So in second-degree heart block, some P waves conduct and some do not. And if you have so-called Mobitz 1 block, then typically what one sees is a grouped beating with a progressive prolongation in the PR interval followed by a drop beat, versus Mobitz 2 or sometimes Mobitz 2 block, which is where there can be normal conduction and then randomly you see P waves not conduct at all. Some people will make the distinction and say another form of second-degree block is so-called 2-to-1 block, where you see 2 P waves for every QRS. But 2-to-1 block is likely either a form of Wenke block or Mobitz 2 block. It's just hard to make that determination from surface electrocardiogram. So looking at the electrocardiogram, presumably if the patient is in high-grade second-degree block, the chances are you're going to see some P waves that are not conducting. But the real key is the R to R interval fixed or not? And are there any P waves that seem to conduct even with a long PR? And probably the quickest way to tell that is if the RR is not fixed. If you're seeing a QRS that's coming in earlier than all the other ones, the chances are that probably there is some conduction. In other words, it's not complete block.
No, that's great. In my time working in the cardiac ICU and hanging out with cardiologists, something that I learned quickly is that precision in language is a high priority in all medicine, but especially in cardiology, where details really matter. You've mentioned high-grade AV block and also all the different types of heart block. What does high-grade AV block actually mean?
I think in general, when people say high-grade AV block, they usually are meaning that it's either Mobitz 2 second-degree heart block or third-degree heart block. And I think as a general rule, most people use the term high-grade block when they are not sure if it's complete or Mobitz 2 heart block. I think it's sort of a shorthand way of saying, this is a serious degree of block. I'm not sure what it is, but this is an important problem that needs to be evaluated and managed in an expeditious fashion.
Yeah, and it seems by high-grade AV block, if you're having impulses not conducted from the atria to the ventricle, you're going to have ventricular escape beats or wide QRS complexes. Is that a true statement, or is there subtleties there that I'm incorrect?
Well, you can have an escape rhythm of any type. You can have a wide escape rhythm, or you can have a narrow escape rhythm. I'm not sure that one is definitively more dangerous than the other. I guess if it's wider, it implies that the residual focus of depolarization is lower in the ventricle, and as a general rule, the further down you are in the conduction system, the less reliable the heartbeat is. The area of the greatest automaticity in normal human beings is the sinus node. And probably the second most automatic of tissues in the heart would be the AV node or the bundle of His. And then as you move down into the ventricles have their own degree of automaticity, but it's very unreliable and it's often slow. And the higher the automaticity is coming from, the narrower the QRS is, because it presumably is coming from an area near to where the AV node or the bundle of His is. And so as a general rule, probably if the QRS is wider, it may imply, and the patient doesn't have a pre-existent bundle branch block, it may imply that it's a lower focus and maybe a somewhat less reliable focus. But I really would mostly just go off of the heart rate in terms of managing it acutely. I don't know that it really matters as long as there's an adequate heart rate to maintain perfusion and blood pressure.
I think you're getting at this when we're looking at anatomic classification. There seems to be a focus on the intrahiscian block versus the infrahiscian block. And so you've got the SA node, the AV node, the bundle of His, and then the left and right bundles. Is this something that you find clinically important, the intra versus infrahiscian blocks?
Well, we think about this a lot when we're looking at people who have heart block. So, as you know, when someone has heart block following congenital heart surgery, the general rule of thumb is that we would typically wait 9 or 10 days, and if the heart block were to persist, it's generally recommended that a patient have a pacemaker. That's a Class 1 indication for the American Heart Association. And in those cases, it's believed that the majority of heart block from surgery is infrahisian. So the lower the level of the block, the more serious the block. So in other words, when we say infrahisian, what we mean is there's been either an injury to the bundle of His or to the connection between the bundle of His to the bundles, resulting in heart block. A suprahisian block is usually more at the level of the AV node. Either is bad, but probably when you're thinking about a person who has postoperative heart block, almost always it's infrahisian, and that's based on old literature where people would undergo EP studies, in that circumstance. So we know that that's mostly the case. And so, I think it really matters more what you're seeing on the electrocardiogram, whether it's second degree, whether it's third degree. Ultimately, as you know, we have to treat the patient. And so you can be unstable with second degree block if you have crappy hemodynamics. For example, we've discussed how myocarditis could cause this problem. So if you have myocarditis and you have a second degree heart block, and let's say you're in 2-to-1 block and you have a very poor ventricular function, that may be very poorly tolerated, even though the ventricular rate might be 60. Whereas someone in complete heart block who comes in may not have myocarditis, may have normal function, may have the same heart rate of 60, and may look fine. So really, each patient has to be individualized in terms of their care. One of the things that I always find funny about EP is, especially when we're going into the evening, Mike, critical care colleagues always want to have an algorithm. What are we going to do if this happens, if that happens? And I'm always like, just pick up the phone and call me. And the reason is because it's very difficult to predict, and I think although algorithms are very, very helpful and in framing how we think about things, the devil's in the detail, as in most things. And sometimes these things change, right? If you have heart block because of myocarditis, you could come into the hospital in second degree and have third degree 2 hours later. You could also recover conduction. Maybe you're at the tail end of the myocarditis and maybe it's getting better for some reason. It's hard sometimes in EP to predict what the algorithm is going to be. So unfortunately, it's good. It means that I still have a job.
Oh, absolutely.
I appreciate the commitment to detail there. And I was going to say that there's very few consults that I want called faster than my consult to EP. Alice, did you have something?
Oh, I was going to say that, yeah, like you're alluding to, the first test for a patient in heart block is the lactate. Just kidding.
Oh, yeah, that's right.
Kind of.
And mental status.
Yeah, that's important, right? I had Tony Rossi of Nicholas Children's on my podcast a few times, and he's shown, as have many people, if the lactate is good, you're probably going to be okay. And if it's high, you're in some deep weeds.
Yep. So up to this point, you've done a great job giving us framework for how we think about AV block. And we appreciate you kind of leaning into this, even without an EKG in front of you, of course. Reflecting back to our case, so EKG shows high-grade AV block with greater than 2 consecutive non-conducted P waves and some preserved AV conduction. She continues to have poor perfusion after initial fluid resuscitation. So assuming that pulses remain present, i.e. she doesn't need CPR, and this AV block is not the result of a specific toxidrome, like calcium channel blockers or something, what would be your recommendation for the initial evaluation and treatment?
Well, I guess I don't know that maybe you guys know if there's some formal AHA recommendation for this. I'm actually not aware of that, but I would normally consider using isoprel in this circumstance. And you have to be careful, though, with isoprel. So the benefit of isoprel is that it could potentially enhance AV nodal conduction. That would be the reason to use it in theory. But if there is a fixed problem with the node, it could do something bad. It's going to definitely increase sinus node rate. And so it paradoxically may make the block worse. In other words, you might be 2-to-1 with an atrial rate of 100, and then on isoprel, you might be 3-to-1 with an atrial rate of 150. And so, as in all things, you try it, but you have to be very ready to turn it off. Good thing about isoprel is it's gone very quickly. The other thing about isoprel is it can cause vasodilation. And, we use a lot of isoprel when we do electrophysiology studies and ablation, so we have a lot of experience with its use. And, even in these healthy patients, we see a little bit of hypotension and they get a very wide pulse pressure. You get these water hammer pulses in the groin. But I would say that would probably be my own personal view. You could also use atropine, which could, enhance AV conduction. Could work the same way, though, as the isoprel. It also can make your sinus node faster. And so it may or may not be the right thing to do. But I think neither of them are wrong. The thing about atropine you should be aware of, though, is it lasts a long time. The effect is in multiple hours. So one of the reasons I kind of prefer isoprel is if you don't like what you're seeing, you can turn it off. I don't think it's likely atropine is going to cause any major problems for you, but my first go-to would probably be isoprel in that circumstance. And if you don't have isoprel, you can do something like epinephrine or something like that, as long as you have a good line. Of course, it's fascinating, but you can save somebody's life with a little bit of epinephrine, and if they have a 1 millimeter skin burn from an infiltration, that is all you will hear about for the rest of your career.
Yes. For sure. Well, this is really valuable because I know in the PICU we're fast to throw atropine at bradycardia. Can you explain what's happening in the conduction fibers, why a faster sinus rate wouldn't lead to a faster ventricular rate?
So, the problem is because you don't know what's causing the heart block, you don't really know what's going to make it better or worse. And so the reason you would start isoprel is you would hope that maybe it will enhance conduction in the AV node and the his Purkinje system, that maybe in the setting of a higher adrenergic tone administered parenterally, such as isoprel, that the AV node and the his bundle will conduct better, and you will, instead of being 3-2, maybe you'll be 1-1. But it's also possible that it will have no impact on the AV node or the his Purkinje system, but it will almost always have an impact on sinus node function. In other words, those agents always cause the sinus node to beat faster, unless you have some sinus node disease, which is not the case in this patient. So you know for sure when you give isoprel that you're going to have sinus tachycardia. The question that you don't know the answer to is, are these P waves going to start conducting through the AV node? Is the impact of the medication on the node and the his adequate that it's going to start conducting and you're going to see more conduction? Or is it going to have essentially no impact on AV node and his conduction, in which case you'll just basically be enhancing sinus node automaticity in the absence of any impact on the AV node. So you'll paradoxically actually have less conduction because the sinus node is getting the full impact of the isoprel on the AV node and his Purkinje system not really seeing almost any impact. And it's very hard to predict, which is why you have to sort of sit there and watch and see what happens with it. In my experience, usually it doesn't really help the conduction, but it could also enhance the automaticity of the escape rate. So it may not improve the conduction, but you may go from an escape rate of 60 beats per minute to an escape rate of 80 beats per minute. So even though it may not work at the level of improving the conduction, it may actually increase your ventricular rate, which may be adequate to have stability in the patient while you take a breather and decide, what's going on and what a better long-term solution is for the patient. That, in my experience, is what usually happens, is that the node does not really start working better, but usually the escape rate gets a little faster and, the positive chronotropy on the ventricular escape rate is enough that the patient is a little bit better. But again, it's not a guarantee, so it's a little bit trial and error, and each patient is different.
Oh, we know that listeners never dose medications based on a podcast alone, but the isoparenteral dosing that you use at Sinai, where are you starting it? What's your max?
I think you would normally start at 0.1 mic per kilo per minute and maybe go up to about 1. In the cath lab, we just I don't even know half the time what we're doing. We're just sort of dialing it in to get effect, to be honest with you.
More or less, yeah.
30% increase in heart rate. But I think that's a reasonable low dose to start at. And usually you see an effect within 5 to 10 minutes at most. And so if you don't see an impact in the heart rate, good or bad, then I would probably maybe just double the dose. And it usually becomes very obvious when you start to see the effect. It's not subtle.
No, that's great. Use isoprel, isoparenteral, with guidance from electrophysiology, of course. Listeners will remember this is a non-specific beta agonist, so you get increased chronotropy, but also vasodilation, so you got to watch out for hypotension. As I understand, there's also a real risk for arrhythmias. Will you kind of review some of the toxicity or side effects we need to be aware of using this medication?
Yeah, well, just like all adrenergic agents, it's definitively can be pro-arrhythmic. And so you can have VT from this, for sure. One needs to be very careful. And again, that's why it should only be really administered either in the cath lab or in a monitored setting such as the pediatric ICU or cardiac ICU, because of exactly what you're describing, which is it can be proarrhythmic. In fact, the reason that electrophysiologists have so much experience with it is because we are intending it to be proarrhythmic. When we have done an ablation, we want to know before we pull catheters that arrhythmia is not coming back. And one of the ways in which we do it is by starting isoprel and aggressively pacing the heart and trying to trick the heart back into tachycardia. And so we are actually trying to take advantage of the proarrhythmic effects of it. But in the example that we're discussing, we're most definitely not using it for that purpose. We're instead trying to get better chronotropy in an urgent setting. And I would say, though, in this particular case, with the patient being hypotensive, it might make more sense to think about using something like epi, because it would kill two birds, both get you more blood pressure and get you more chronotropy. So I think most people would not use isoprel in someone who's, 80/40 and hypotensive. I think in this particular example, it might make more sense to try to use epi. But again, all of the same concerns exist for epi as for isoprel in terms of possibility of proarrhythmia, possibility of higher grade block, possibility that it doesn't do anything good or bad. But I think if you have a hypotensive patient, perfusion is kind of marginal. I think epi would probably be my first line in that type of patient.
In my little bit of experience here, I've never managed a patient both on epinephrine and isoproterenol, and the scenarios that I've taken care of them, we've swapped one to the other based on their perfusion and their blood pressure. Is that your practice as well? Only one or the other?
Absolutely, yeah. It would really be weird to be on both.
Yeah.
I mean, epi should get you everything that you can get with isoprel, plus a bunch of other things which are both good and bad. But again, what we're talking about here is acute management to sort of get the patient stable, and then your job is sort of a combination of overall care but also emergency care. So you really got to get that patient stable so that then we can take a breather and figure out what actually is going on and how we're going to, get this patient into a more stable situation where they no longer need to be on epinephrine.
So staying in that emergency mindset, if despite titrating epinephrine or even isoproterenol, our patient still has high-grade AV block, still has signs of poor perfusion, maybe the lactate is increasing, what might be your next recommendation in a scenario like this?
Well, in that circumstance, I think this patient in this example is like 7, is that right?
Yeah, 7, 8 years old, yeah.
7 or 8 years old. In that circumstance, I would probably think about possibility placing a temporary transvenous pacing catheter. In other words, the patient is becoming unstable but is not yet unstable, and I think a transvenous pacing catheter is good because it can provide many hours, possibly even a day or two of support. It does not carry some of the risks of other ways of pacing, which we can discuss. And it could potentially be done at the bedside. So typically, if we need to put in a transvenous pacing lead, we now have these terrific leads that have actually a balloon on the end of them. They're a bipole catheter. Typically, they're 4 French, so it could pretty much fit in a child this age very easily. But the key is you can really only put it in at the bedside if you're putting it in the right IJ, because that's a fairly straight shot to the right ventricular cavity, RV apex, etc. It's very difficult to place a pacing catheter in the ventricle, like from the groin, without fluoroscopy. If you happen to work in a unit that has fluoroscopy, sure, you can do that. But I think even if I had fluoro, if I had my druthers and I could pick any location, I would certainly always choose the right IJ, because not only is it more likely to go quickly into the right place, but it also is more likely to stay in the right place, because the distance from the entry into the jugular vein to the ventricular apex or anywhere in the ventricle is much shorter, and so there's much less opportunity for movement of the patient to cause problems. It's also better tolerated in general. People feel much more comfortable with IJ access than they do with groin access, much lower risk for infection, etc. So that would be my approach. And you could do that either with echo guidance in the ICU. You could also just basically float it in and have it pacing at a certain rate until you see capture, and then do an X-ray if you wanted to. I probably would do both, honestly. Get an echo while I still have everything sterile so that if I don't like the position, if it looks unstable or whatever, I have the opportunity to manipulate it. But yeah, that's what I would certainly, that would be my first choice. Now, it's important to remember that that is not an option in very small children. So, for example, if you had a 6-month-old who had heart block, we would never consider doing that in that age patient. And the reason for that is that, particularly in babies, even younger than 6 months, the likelihood of perforating the heart is very, very high. Even if you put the lead in perfectly, I'm not speaking of the operator actually pushing the wire through the heart. What happens is that in a small, thin heart, as is typical of any healthy baby, I think you pretty much can guarantee a perforation over time if it's in there for more than a handful of hours. So it's not a good idea in small children to do this. But in someone who's 7 or 8, I think we could confidently place one without worry that, at least for the short term, meaning a few days, it's unlikely to cause a problem.
So you alluded to there might be other ways to pace the heart, like transcutaneous pacing. I do want to bring us back to that in a moment. But I'm just imagining at the bedside, looking at this child who I kind of consider to be unstable. Like, I wouldn't walk away from a child with a non-sinus rhythm who is poorly perfused. And then I have this wonderful electrophysiologist who says, I can place a transvenous pacer. And I'm looking at this kid whose maybe mental status isn't perfect, perfusion is impaired. And I'm thinking, how am I going to get this child to safely lay still for this procedure, this life-saving procedure? And like, the last thing I want to give this child is propofol or, Versed. Like, what kind of clinical setup do you need to emergently place a transvenous pacer in a critically ill child?
Well, you're bringing up very important points. I mean, I think I would say you need somebody there like you who's able to intubate the patient and anesthetize them. I mean, and you need to be ready for that, basically. And I think probably it's a risk, there's no question. But if you're really worried, if your lactate is rising, as they say, desperate times require desperate measures. And if your patient is circling the drain, as you're describing, then you need to take care of matters and do that. I mean, what would be some other options, right? So you could transcutaneously pace, as you said. The problem with transcutaneous pacing is, first of all, it's very painful. So if you're worried about a patient who is, awake and talking to you, that is really not a good thing to do to anybody. Second, in my experience, people often don't know how to transcutaneously pace. I've seen some very experienced people think they were capturing the heart and they were not, with bad outcomes. So again, it's not to say that it doesn't work, but you really need to know what you're doing. And the problem is, it's extremely rare that we transcutaneously pace people. I don't know anybody who's done it more than 2 or 3 times in their entire career. I'm sure many intensivists have never done it. And so, you're in this desperate situation, and the first time you're going to do this is when somebody's life is at stake. So it's a difficult thing to do in that circumstance. And I would caution anyone who's listening that you cannot transcutaneously pace babies. You will uniformly, within 30 to 60 seconds, get second or third degree burns. So that is not an option in small children, very small children under a year of age. So if anyone's wondering, like, why have I never seen that? It's because you will literally burn the child if you try to transcutaneously pace a very tiny child. So in that circumstance, what I would recommend if someone is that desperately ill is I would do CPR. And I would call a surgeon. When I see someone in heart block who's very little, where I don't think I have many good, non-invasive approaches, I call surgery right away. Because the truth is, it's not a big deal for a surgeon to put a temporary epicardial wire on anybody. They can, through a subxiphoid incision, get to the heart in 35 seconds, 45 seconds, and put something on there to get pacing. And so, if we take it back to this example, if you're really either way, whether you're going to put in a transvenous line or you're going to put an epicardial line, that has to be done under anesthesia. And so, unfortunately, we have to bite the bullet and do it. It's sort of analogous to when you're doing a pericardiocentesis in someone who's hemodynamically embarrassed, and the last thing you want to do is give them a lot of anesthesia because you know that that's actually the biggest risk of the procedure. But sometimes we're just, as they say, you're caught between a rock and a hard place, and you just have to suck it up and, that's why they pay us the big bucks to take care of these very difficult situations. So, you try to avoid those things. I do anything to avoid that. But, if somebody is really dying because of chronotropic incompetence, then we have to get that heart rate up one way or the other. And if the only way to do it is going to be to anesthetize the patient, well, then what you can do is have everybody ready, not anesthetize the patient and then call electrophysiology or then call the surgeon. One of the things that I've seen both in the type of circumstance we're discussing, but also in postoperative patients who get heart block and maybe don't have wires, is people forget to call the surgeon. While other people are doing all sorts of different things, somebody should be picking up the phone and calling the surgeon who's on call and say, hey, we got a tough situation here. We're probably going to need you. Because again, it's not that hard to put an epicardial temporary wire on somebody, and it could absolutely be life-saving. So even if the surgeon's not coming in, it would be rare to find a cardiac surgeon who would be upset to be informed of what's going on. I would almost guarantee any surgeon worth their salt would start coming into the hospital if you told them the situation you're describing.
Oh, absolutely. First of all, such great clinical pearls, and we really appreciate that. It's interesting to me thinking about calling the cardiac surgeon for a non-surgical patient, someone with a new diagnosis and unstable heart block. Odds that they just get pacing wires and don't end up on ECMO, right? I'm thinking through like the typical clinical pathway. They end up on VA ECMO, but that's just because I've never seen pacing wires in that situation.
Well,
right?
That's because, we're looking at this in an isolated manner, right? The likelihood is the patient like this does have myocarditis and probably does have crappy function and probably will arrest. In other words, if you or I had a heart rate of 52, we might not feel great, but we would not have a lactate of 7. So, we haven't really talked about this, but someone who presents with high-grade block, someone should be pulling an echo machine over or a point-of-care POCUS machine to at least take a look at the function, because these things don't usually come in isolation. It's possible that you could have one without the other, but they tend to come together, right? If you saw somebody with this heart block that you're describing and they had terrible function, you would immediately have narrowed the differential diagnosis, and you would be calling the surgeon for ECMO backup, right? You would be saying, well, I got to get the heart rate up. Maybe we should go on ECMO first. In fact, you would probably not want to pace the patient at all. You would probably say, well, this is going in a very bad direction. My CRP is very high. My lactate is very high. We should go on ECMO before we arrest. And probably with time, both the function and the conduction will recover. So, all this conversation about pacing assumes that there is not something else going on. But the reason that most of us have never seen the scenario that we're describing is because most of the time it's not isolated heart block. The AV node and the conduction is an innocent bystander of something much worse that's going on. So that's all I would say.
Oh, excellent. Now, I have a question. Dr. Pass, let's say that it's the snowstorm of 2026. You're at home. I'm covering the cardiac patients at Sinai, and we need to transvenous pace someone. Can you walk me through that procedure, the equipment, what we're doing? Definitely appreciated that, okay, now it's time for you to put the breathing tube in. But what happens next?
Well, generally, the first thing you do is you have to have a vascular sheath. You have to have all your equipment next to you, as is the case with all procedures. You need a balloon-tipped bipolar catheter that can be placed transvenously. You can use other catheters, but that's probably the least toxic one. It's only 4 French, and it's less likely to perforate. Also, having a balloon on the end makes it a little easier to float it into position. You need a temporary pacing device, like the ones you use at the bedside. One of the things that's important is you need, in the catheter kit, are the adapters that allow you to plug the back of the catheter into the pacemaker. It turns out that transvenous catheters, about 20 years ago, law came out that they had to have plastic around the tips. And so all of the connectors in the cath lab are designed to allow those to plug in independently. But most of the connectors in the ICU, you need to actually use these little adapters that come in the package with it and put them onto the ends of the tips of this catheter. And then it will allow you to plug it into the pacemaker connecting wire. That's an important little point. You don't want to lose that. Now, that end is not sterile. The point is, don't throw out the container until you get those 2 little adapters that almost always come with the catheter, or else you'll be you'll have a catheter in position and no ability to pace. It's sort of an important practical point. And then if you're trying to put it in, then I would probably attach it to the pacemaker, maybe set the output at 10, use an ultrasound, obviously, to get access in the IJ. And then I would just basically, I would look at the patient and maybe even measure out what the distance is, because you're doing it blind, and because the catheter you'll be using may be 100 centimeters long and you may only be using 30 centimeters, it's important to remember that you shouldn't just keep pushing it in if you're not getting capture. Chances are you're putting the catheter somewhere it doesn't need to go. I would just, start the pacing. I would, in my own mind's eye, know I don't want to put in more than a certain length of catheter. If I don't see it's working, chances are I'm doing something wrong. Either it's going lateral and not anterior into the ventricle, or maybe it's going down the inferior vena cava. Or so I would, pull the catheter back and maybe turn the catheter 25, 30 degrees, try again, that type of thing. But, again, it's very important to keep track of what the distance is between your vascular entry and where you think the right ventricle would be. And chances are it's less than a third of the length of the actual catheter you have. Unless Shaquille O'Neal is on the table, you're not going to use a lot of that catheter. And so it's important not to just keep pushing it in until you see capture, because if you've got 3/4 of the catheter in and you don't have capture, it's likely not in the right place. It's not a technical problem with the catheter or the pacing. And then once it's for position, you can then tape it into position. You can put, do all the things to keep it sterile. But importantly, you can't pull it in and out. So once it's in, it's in. And so you can pull it out, but you can't put it back in because the part that's outside of the sheath is no longer sterile, which is why I would probably not tape it until I got an X-ray or an echo to confirm the position.
I can imagine as you're advancing this catheter, you're looking for electrical capture on the telemetry, but also mechanical capture, like you're seeing a nice blood pressure. If we had an arterial line, you're seeing a good tracing there as well, and a pleth on the pulse ox. If we did get a chance to get an echo during that procedure, or you're looking at it on X-ray, anatomically, where does this catheter end up at? Is it kind of towards the apex, so to speak, of the right ventricle, or somewhere else?
It could be towards the apex. It could be in the right ventricular outflow tract. Usually in a child of this size, I would say you probably could do it reliably most of the time. I'd be surprised. The reality is, if it's capturing and and again, if it's a right ventricle pacing, this ECG will typically show a left bundle morphology. That's important because it would be hard to do, but not impossible, to inadvertently pass a catheter across a PFO into the left ventricle. That would be bad because that would raise the chances of a patient having a stroke. So one way to sort of tell is, of course, to do an echo, which would be very obvious it's in the correct chamber. But at least on a temporary basis, once you have it in position and you have ventricular capture, it would not be wrong to do a 12-lead, because if you have a left bundle branch morphology, that would almost always denote that you're in the right ventricle, the correct and the right-sided ventricle, right anterior ventricle.
And you said a balloon-tipped catheter. At what point are you inflating the balloon?
I would say once you think you're in the right atrium, I would then inflate the balloon. And you can guesstimate that based on the size of the patient, where you've gotten vascular access, et cetera. Typically, it's going to be maybe 1 or 2 feet of catheter in the patient, maybe 20, 30 centimeters, something like that.
So this has been excellent. I think I've learned more about transvenous pacing up to this point than I have prior in my career. It's one of the wonderful things about having electrophysiologists on the podcast. I think it would be helpful to get a little bit more information on transcutaneous pacing, like perhaps in an emergency, just because it's such a low frequency event. Dr. Pass, will you tell us, at what age might transcutaneous pacing be a short-term, the solution's too strong of a word, but short-term strategy to increase cardiac output, and then give us some tacit knowledge and some practical tips about pad placement and how we might titrate this therapy until our electrophysiology friends get to the bedside.
Well, I have to be honest in saying my experience with this is minimal, as is the case with most people. So I have a little bit of experience, but not very much. I guess the first principle I would say is that if you need to be transcutaneous paced, you need another plan, because that should, in no patient should that be, set it and forget it. That might be okay to get you 15 minutes until something better comes your way, but really it's not a great solution for anybody. And why is that? First of all, we talked about the fact that it can cause burns. It can cause burns even in bigger patients. And so you really don't want to be doing that for more than a couple of minutes, I think. I don't have experience with anyone getting it, an adult-sized patient having it for a day, but my suspicion is very high that you would at minimum get second-degree burns. I mean, when you electrically cardiovert someone with pads, you get a first-degree burn 100% of the time. So it's not shocking, to use the term, that somebody would have burns associated with pacing. And again, in small children, I'd say probably under 1 or 2 years of age, I would be very reticent to transcutaneous pacing, and I would rather just do CPR, quite frankly. And again, it highlights why calling the surgeon is very important, and also highlights why getting an echo is important, because just as Dr. Shanklin implied and discussed earlier, the likelihood is high that something bad's going on in the heart and that the rhythm is indicative of that, but is probably not the main reason the patient is falling apart in front of you, which is, again, why you don't see a lot of transcutaneous pacing, because almost always when they're in heart block, it's like 3 other bad things happening that are worse that explain why you're in trouble. So, it's also true for little kids who had heart surgery. If somebody is in post-op and is bradycardic, you want to do CPR on that patient. You don't want to be transcutaneous pacing that patient. You can open the chest and have someone do, direct cardiac massage. You can just do regular old CPR. Works very, very well, obviously. But, while you're doing that, someone should be picking up that phone and getting your surgical colleague in there to immediately assist you. Because if it is exclusively heart block, that's going to be very easy to solve. Now, in terms of pacing in general, if you have someone who's fully anesthetized, the general rule is you start at a high output like 200 and you come down. But in somebody who's awake, they generally recommend that you start at a low output and you increase it slowly until you get capture. Now, here's probably the most important aspect of pacing, and probably your audience already knows this, so I apologize if I'm saying something that everybody knows. But the problem is that you capture the skeletal muscle in the chest at a fairly low output, and the threshold for capture of the cardiac myocytes is usually higher than the threshold to capture skeletal muscle. So probably the single biggest mistake that people make with transcutaneous pacing is that they mistake skeletal capture with cardiac capture. And so how do you know whether you're capturing the ventricle rather than the skeletal muscle? And the answer is the EKG, the old favorite of me and everybody else. So a lot of people make the mistake, they look at the EKG and they see this massive spike. Because remember, when you are pacing transcutaneously, the pulse width or the duration of the delivery of the energy for each spike is very wide. You can't capture unless you have a very, very long pulse width to do transcutaneous pacing. So it makes a gigantic artifact on the EKG. It's so big, in fact, that most people inadvertently or incorrectly assume that that is the QRS or that that is a demonstration of capture of the QRS. But you actually have to see a QRS after every one of those spikes. And that is the mistake that I have observed, which is people see the skeletal muscle capture. It's kind of scary to watch, honestly. You see these massive spikes on the electrocardiogram, so you assume, you're capturing, but you're not. You're capturing skeletal muscle, not cardiac muscle. And so you really have to run the EKG and see. Now, if you have an A-line, you can certainly see if the arterial tracing or the pleth on an O2 sat monitor are similar to the rate that you're pacing at. That's certainly another way to tell. But oftentimes in a patient like this, the cardiac output is so poor, your blood pressure may be very low also, so it may not be a very good way to do it. But the ECG should tell you the answer to that. But you really do have to look at the EKG and scan it carefully, because you can very much be fooled. And I've seen that. I've seen a very, very senior intensivist make that error. So you have to be very careful about that.
In that setting, when you saw that, right, you were looking at things in post. Is the idea that they started at low output, just got the chest wall, and then didn't go up enough on the output to get the heart?
Yeah, presumably they weren't at a high enough output. In fact, when I walked into the room in that circumstance and saw what was going on, the first thing I did was run to the patient and start doing CPR. Because I didn't know how long the patient had been left in that setting. It might have only been 10 seconds, but it might have been 10 minutes. I actually was coming in from home in that circle. This is many, many years ago.
Oh my gosh.
But I was literally coming in from home because I heard what was going on. And when I walked in and I saw that, I immediately just jumped on the patient and started saying CPR. I looked a little bit crazy, but there was non-capture. So it's a very important distinction. And again, I think the reason that none of us have seen this very often, I've only seen it maybe 2 or 3 times in 30 years of being a pediatric cardiologist, is because almost always the problem is multifactorial. Like, again, you wouldn't transcutaneous pace someone who has horrible myocarditis and is dying from bad function. You'd call ECMO or something like that. And in those cases, right, we're usually just doing CPR while we're waiting for the surgeon to, cannulate the neck or however they're going to put them on.
Yeah. Well, thank you for sharing that with us. That's definitely a powerful example of a pitfall.
So I really appreciate you maintaining this facade of imagination with us as we've worked through this case. Of course, children who are dying of cardiogenic shock, if the ECMO is available, gosh, ECMO is a great next step. But it's been so helpful to kind of get into your mind and you sharing how you think about these patients. And what I can already gather is that when these patients show up with, a new diagnosis of high-grade AV block, this is a symptom. This is one of the first hints of something, more sinister likely driving all of this. And I can see just the diagnostic wheels turning in your mind when you're trying to think what exactly is going on here. You've already reviewed several pearls and pitfalls for us, but did any more come to mind that we haven't gathered thus far in managing children with high-grade AV block?
I think the most important thing is exactly what you just said, which is that almost always something else is going on. And, heart block in the post-op patient, that's very different. In those cases, usually the heart block is the problem. That, in other words, if someone is in heart block and they're not conducting and you're not pacing them, usually that's the main problem. Yeah, you can have a bad surgery or whatever, but assuming everything was done properly other than getting heart block, in those cases, yes, urgently and expeditiously getting pacing going is the key. But in the case of someone who's kind of walking off the street, as in this example, the likelihood is high that there is, as you said, Dr. Hodges, something else is going on. And so, it's I sometimes joke, everybody dies of bradycardia, but it really wasn't the bradycardia that caused them to die, right? It just was the final common pathway. And so I think that when it comes to seeing heart block in a previously healthy 7 or 8-year-old, it's unusual that it would come independent without something else really bad, especially if they're syncopal. Again, it could be you can get myocarditis and it only affects the conduction system. I've seen that. But almost always, it's something very sinister like a terrible metabolic disorder or a very bad infection or viral or bacterial, something like that. So I guess I would say, try to stabilize the patient and then try to quickly figure out what's going on. And again, I know we talked a lot about transcutaneous pacing, and there are certainly patients in whom it has saved lives. There's no question. But I guess I would say if you find yourself doing a lot of transcutaneous pacing, probably something is wrong, at least in children. That's what I would say. I've been doing enough EP over the last couple of years. If I'm not seeing a lot of it, then I would say probably you shouldn't be seeing a lot of it either.
That's great. Wise words.
Yes. Well, Dr. Robert Pass, thank you so much for joining us today.
It's a great pleasure. Thank you for having me.